My name's Alan Rozanski, and I'm here at Dr. Berman's course, the 31st annual course on advances in nuclear stress testing and cardiac CT. It's been a pleasure to be here to hear the excellent lectures. It's always a great joy to come back and to participate in this program. Dr. Berman asked me to speak today on the changing paradigms which affect, the use of nuclear stress testing. And we had an hour talk where we examined 4 basic paradigms: the role of the use of the Diamond-Forrester algorithm for Bayesian analysis, the role of calcium scanning in asymptomatic patients, how we assess test sensitivity, and also looking at the issue of comparative effectiveness research, where we're comparing, now that we have so many tests, which test in which patients. So during the course of the talk, we explored which of these principles and paradigms that we began to use 30 or 40 years ago are still, correct today and which are not. And we found, actually, I think with the use of the examination of the data, the evidence-based data, that most of these paradigms, in fact, have not well stood the test of time for different reasons. So that means how do we approach the diagnosis of patients? How do we approach the work of asymptomatic patients? And importantly, in fact, what's the best testing algorithms to use for, evaluating patients for both diagnosis and prognosis? So we, I think, explored this well, and we painted a large future role, I think, for calcium scanning. Beyond its screening purposes, we explored the use of calcium scanning with treadmill testing together. And then we explored a very important issue that, as we have seen a decline in the frequency of ischemia, and most patients today have normal stress tests in the diagnostic population, still the long-term risk varies in these patients according to whether they could exercise and risk factors, and therefore we explored the need to come up with a new paradigm for evaluating patients and characterizing the risk both in terms of short-term or ischemic risk and long-term clinical risk. And we developed that concept, and I think there was a lot of reception and understanding in the room as to the utility of this. And all in all, it was a lot of fun to put it together.